Okay, so maldeparkment syndrome, where you feel like you're still on a ship even though you're walking on dry ground. So this is a side view. This was one of the first x-rays that was taken of you, showing how there's anterior slippage of these vertebrae. They don't line up. And you can even see that this looks like it's hyperextended. This is an x-ray we took, actually we took one today and just a couple weeks ago. They look very similar. And you can see how they're already not stair-stepping as much from the prolotherapy that Dr. Hauser's doing. Yeah, so already that's improving. With the weights that you're doing, I'm super impressed with that. Okay, so we did a CT angiogram with venous phase. Actually, this is an arterial phase here. These are venous, and this is a venous too.
What's the difference in arterial and venous?
So,
arteries and veins.
So this is with you in the neutral position. This is with your head turned to the left. This is with your head turned to the right. And this is with your jaw jutted forward. Okay, so I can tell you what set you up for injury is that, here I'll show you. On the back of this vertebra, on the left side, C4 is not able to extend onto C5. There's some calcification in here that I'll show you. As a matter of fact, you can see it better here. So here we have you in left rotation. You can see that nasty calcification. I'll show you on the left here. This is you in neutral with all this nasty calcification built up. This vertebra will not slide into extension here. And when you turn to the left, it is not moving at all. It is locked in there. You can see the vertebra above it sliding into extension. And actually, I can assure you, let's show you everything it does. So the atlas rotates quite a bit off of C2. C2 slides into extension on C3. C3 really slides into extension on C4. So quite a bit, actually, maybe a little too much. And then this one is not moving at all. It's not able to show up to the party and do anything. And that's the left side. Here we look at you now on the right side, down at C5, C6, you got the same problem, only worse perhaps. It is calcified down in here. It is not moving. It will not go into extension, allowing that vertebra to go posterior too much. Now here we are with your head turned to the right. You can see that there is some movement in there. It is not completely fused. So here we are in the neutral position where it's all, calcified in there. Right, it tries to come out of it, but it will not go into extension because of this calcification. So we have, and when we had you, actually we don't need to look at the, well, this is the one where you jutted your jaw forward. One of the reasons we cared about this is because the ultrasound measurements show that there was a change in the jugular vein up in here. And you can see, I can probably remove a lot of this. Yeah, you can see the indentation. That's probably from the Ohio, the posterior belly of the, posterior belly of the digastric muscle. When you jut your jaw forward, putting a little pressure on the jugular and kind of pushing it into the atlas. You can see how it dents in there. And there you are, jutting your jaw forward. Really doesn't do too much on the left side there, so much. But this is where a lot of the actionable information is here, especially when it comes to treating this stuff. Okay, so what we already know is that one of the doctors came behind you and picked up your head and supported it as you walked, and that made you feel much better. And that is because C2 on C3 and C3 on C4 are stuck in extension. Let me see if I got some good shots of that. Let's see here. Yeah, I really like how this one looks. There you are in neutral. There you are in right rotation. Okay, I'll move this jaw out of the way. So when you turn your head to the right, C1 pretty much slides entirely off of C2. It's hypermobile. That needs to be stabilized. C2 on C3, the facet is almost vertical and wedging open. Let's see here. Oh, here's a prettier shot of it. You can see the facet is pretty much straight up and down.
Right.
And what's happening is the weight of your head, your head is too heavy. All this is, the ligaments in the front are just wedged open here and here. You can see it beautifully. Yeah, I mean, it's functionally not able to hold you up. And really it's coming from the fact that C4 and C5 and C5 and C6 are stuck, not able to come back. So the only extension you have is between well, C2 and C3, C3 and C4. And actually the atlas moves quite a bit too. So when you were hyperextended in the dental chair, there was no, these vertebrae here were not going to extend. They weren't going to give you any extension. So when you were forced into extension in the dental chair, the only vertebra that could move were these two, and they ended up being ripped open because the facets are ripped open on both sides, and all of a sudden the weight of the head falls down behind. There's nothing to support the head. The head, as you already know, we need something to hold that head up. So you need prolotherapy big time in C2, C3, C3, C4 bilaterally. I mean, that should be where the lion's share, I mean, in my opinion, where the prolo would go to try to close that back up. Again, we look, right rotation. Let's clean that up a little bit. Right rotation, you can see how the atlas is coming off of C2 quite a bit. Neutral, you can see C1 sits on top of C2. Yeah, not exactly perfect.
The atlas shouldn't be moving.
Well, everything's supposed to move. The burden of motion should be shared among all the vertebra. When some vertebrae are stuck and not doing their job, then the vertebra above and below it have to do double duty, and they end up getting sprained and torn. Yeah, I'm going to say your atlas is coming off of C2 too much. Let's see if I can move that out of the way. Really, man, this C3 on C4 is really probably one of the biggest injured. You know, we need all this stabilized. Now the question is, well, if it moves too much, you want it to move less. And if it doesn't move as much as it should, you want it to move more. So we want somebody to come in and clean these facets up arthroscopically, so these will start moving. So this is not the only thing that can move. I mean, that's the gist of it. As far as your jugulars go, I don't think that's what's giving you most of your symptoms. I think this is what's giving you most of your symptoms. Yeah. Any questions?
Are they fused together like cement?
Right, so
they're locked?
I thought they might be. And by the way, there's a lot of details I didn't give you on this. But I can tell you they do move. They're not fused. None of these are completely fused. They actually move. They wobble. Let's see here. If I can show you. Even this one on the left, your left C4, C5, it cracks open like so there is some movement in there. It's not fused. And if somebody removed all the spur formation around here and cleaned it up, even the spur in the front, as a matter of fact, at locks, there's an anterior lock on the right here. See if I can show it to you. Yeah, basically this is on the right side. Your C5 is so actually your C6. What have we got? 2, 3, 4, 5. 5 is so calcified in the front that it ends up locking right here when I show you with right rotation. So Here's
It
your
locks with 4.
It locks in the front. So the doctor who's going to go in and remove some of this calcification in the back, they're also going to remove, there it is, blocking. There, this calcification goes right here and locks with the vertebra above it. So it needs to be cleaned up in front and in back. And by the way, a lot of your joints are beautiful. You just clean up these 2 joints here. Left C4 on C5, right C5 on C6, get that cleaned up so they can start moving again. Get prolo in the upper C2, actually C1, C2, C2, C3, C3, C4, and wear a collar. Make sure your strides are slow. You can't walk very fast. This head is going to bounce up and down. There is no support there.
I've had the anteriolisthesis for a while.
Anteriolisthesis, right? So you were vulnerable. You were set up before this injury occurred.
Mm-hmm.
So, yeah.
Does this explain my vision being horrific, my left eye being much worse than my right, and the fullness in my head and my pressure in my eyes?
Right. So here's the thing. When we start trying to be led by symptoms, it's easy for the doctor to get led down a wild goose chase. But I can tell you this: when you have these problems, they don't cause everything, but they could cause anything. So they really could cause anything that you're talking about, because we've seen these things get fixed and all these things go away. As an atlas orthogonist, which is my main profession here, adjusting these atlases and changing the way the head loads on the neck, opening up these arteries and veins and the CSF flow, it passes for a miracle for over 30 years in my own eyes. And if I tell people what we've seen this fix, what symptoms it's made go away, nobody's going to believe it. It strains credibility. So do I think it's what's causing all your problems? Or yeah, I do actually.
Right. It's like a ladder. Any vagus nerve stuff in there?
Well, so the vagus nerve runs right next to these arteries, these veins. So let's see here. What's the best shot here? Anything that causes the jugular vein to dilate is going to put some pressure on you run a risk of it putting pressure on the vagus. And really the choke point, let's show you the choke point. It's inside the head. Yeah, we didn't even really talk about inside your head. But I mean, just for clarity, to answer your question. Right, so right here is where the jugular vein exits. And that jugular foramen right up in there. Sorry. Yeah, I know if it's going to give it to us. But basically right up in there, when that jugular vein dilates like that, it puts pressure on the vagus nerve as it comes through there, the glossopharyngeal as it comes through there. We've had people who have difficulty speaking, and we've traced it back to the vagus and recurrent laryngeal nerve and all these different choke points through there.
Is the vagus wrapped alongside the jugular?
It runs next to it.
Okay. 5 weeks after the dental debacle, I had a hairdresser and was left in a sink with my head totally, and it felt like a 180 for about 10 minutes.
An extension, right, and that is your vulnerability. Your head did probably flop back really far there, because the ligaments aren't there really to support it. They've already been sprained. Trying to get a good shot. Well, there's the jugular foramen, and it's completely occupied by.
It's pinched, so when it swells, the foramen's not big enough to house it.
Right, whatever runs through that foramen is going to be under pressure. I've seen the foramen. Let's see if your foramen is eroded. Yes, so I've seen the foramen and the bone erode from all the pressure, and it looks like there's quite a bit of erosion in there on the right side. So here's the story. People are born with certain asymmetries in their venous system and their arterial system. So it's really difficult to determine these shades of gray pathology when they are actually causing symptoms and not causing symptoms. What would be normal for one person, when another person looks like that, they're highly symptomatic. So there's so much variation from person to person. The anatomy changes from person to person. You have to, in my opinion, really spend a lot of time. I haven't been able to do it without spending a lot of time and doing these 3D renderings and looking at the person in the provocative positions, the positions that provoke them the most. That's how I've been able to make heads or tails of a lot of this stuff.
When I put my head back and look to the right, I fall back. I lean back, which I know more symptoms. And we found the answer.
Yeah, your head falls back just when you're walking straight, when you're trying to go weight bearing.
I mean, I lean, my body just starts going backwards, yeah.
Actually, these CTs were done with you lying down. So even when you lie down, you're in extension. You're not, right. You're in trouble, but you live in a day and age when all this can be fixed.
Which is amazing. These are amazing to me.
And when you jut your jaw forward, it does put some pressure on the jugular up in here.
But isn't there, to me, it looks like the jugular on the right is markedly larger than the left?
Yes, it is.
And that's got to be contributing, right?
Well, structure affects function. So you start looking at structure, comparing left to right, doing ultrasound measurements, and there comes a point when the body can't adapt and can't compensate, and the flow becomes slowed. So the flow can be slowed a little bit and the person doesn't have symptoms. I think that it can be slowed to a certain point so that the metabolites of the brain aren't excreting correctly, and you'll have Parkinson's and all kinds of other, ALS and a lot of neurodegenerative brain problems because of this slowed venous system.
Think that can develop from this?
Well, I'm not. No, because yours is going to get fixed.
Right.
You're looking at it now. You're going to be one of the few people who actually has their venous system evaluated and make sure it's optimized. Any mechanic, any 16-year-old boy who's souped up his car knows he has to have the exhaust, optimized for the motor. These veins have to be optimized for the very metabolic brain, so it all drains correctly. You don't want to mess with any of that. You don't want to decrease your exhaust or outflow at all. A motor will build up carbon. I believe a brain will build up metabolites. Mm-hmm. Dr. Debarquement, who invented the MRI machine, he talks about this quite a bit and has done a lot of research on the speed of the CSF flow before and after the Atlas, after the Atlas gets adjusted with the Atlas orthogonal instrument.
There's a component with MDDS that the brain, the eyes are constantly telling the brain where the body is in 3D space, and with the forward passive motion it goes away, and you think that this is being caused by these issues.
Well, you find and fix stuff. You find something, you fix it. And when this gets fixed, some of your symptoms are going to go away. Maybe some of your symptoms don't, and then we work the flow chart. We go till everything is fixed.
We have a starting point, yeah.
Right, but this is the most likely thing. This is the thing that's jumping out at us, especially when somebody picks up the back of your head and your symptoms get much better.
And it still works. We do it every night.
It still works, right.
I get to 15 seconds. The worst thing, when we started strengthening my neck muscular-wise in July with a functional neurologist, I got so much worse. And I got pressure in my head that I've never had, that I now still have, and it comes and goes.
Okay, so look, people come into our doors as physicians, and we treat the most likely thing that we usually see. So the most likely thing that people usually have is not what you have. You're actually in many ways the opposite of what we fix every day. We're often finding people that don't have enough curve in their neck, and we're trying to bring the curve back to the neck. You have an excessive curve in your neck right here. You're wearing a weight from the front, bringing it back to reposition that. Your injuries are unique to you.
more difficult or easy?
Just different.
Different.
It's different. You need to have enough time to slow down and figure out, okay, I did what was supposed to work, it didn't work. Why didn't it work? What am I missing?
Well, it seems like the Prolo, like you said, is already taking effect.
Yeah, it's working.
I had Prolo Wednesday, and then I had the imaging on Monday. I don't think it affected it. We were wondering about the inflammation.
Well,
I think it's fine, obviously.
I don't think he fixed you enough in 2 visits, or I mean, the problem, you're still having the wedging,
Yeah.
The more Prolo he does, the more stable you become, the less you re-injure this. I mean, the weight of your head is too much. You need something to hold your head up while this stuff gets fixed.
Okay.
If you did this to your ankle, we'd put you in a boot and wouldn't put any load on your ankle until the ligament healed up.
Right. We can't.
It's kind of tricky doing that with a head.
Yeah.
I mean, the Philadelphia collar and some of these other plastic collars to hold you. I mean,
like the one I showed you, the Iron Maiden.
right. So,
You can't live in that.
Right. So we know that when you walk quickly, the loads that go through here, it's too much. That's why you have to walk with a short stride and walk slowly, so that the bouncing and the loading is not so great.
What, my stylists are okay? Is that what they're called?
The styloid processes, I mean, here you can see it's digging in here. So, I mean, there is some pressure in there. You can see that.
Oh, on the carot, on the jugular.
On the jugular. I don't think that's the thing that you're talking about most. I think we fix the other stuff. I mean, maybe one day you'll have that cut off, but that's not the next step.
That's not the main offender.